is great.
O-H.
I New Minnesota. Yay.
Minnesota. Oh, I love my Minnesotans. Love you guys.
As we're saying all these states, now the state song is starting to play in my
Yeah.
brain.
Believe it or not, that's something we never had to learn.
What?
The state
No,
You don't
song?
know the state song?
I don't.
Angela. Okay, I will teach you.
I should probably learn it.
Yeah, you should.
Okay, I have a really embarrassing state song story. Arizona turned, it was like our, centennial or whatever, and I was doing community theater at the time, and we were
Oh my God, thank God I
performing.
had face in the pillow. Yes,
We were performing for this like really big state of Arizona organization, and Sandra Day O'Connor was there, and it was like this really big deal. And we did this performance of, Arizona through the past 100 years and all this stuff. And then at the end, they said, okay, now all the performers are going to come out and sing the Arizona song, which I didn't know that there was an Arizona song. I didn't grow up in Arizona. We don't know what the Arizona song is. And as we're all walking on stage, they just hand us a little piece of paper that has the lyrics. And so we're like, oh, Arizona, or whatever. Like, we had no idea what the heck we were doing, but we're singing this like Arizona state song in front of like the most important people in the state of Arizona for its big like state anniversary. It was nice and embarrassing and horrifying. So please make sure you know your state song in the event you get stuck in a situation like I did.
What a great story.
It was something. It was literally Sandra Day O'Connor was like right there and she's singing along. And I'm like, oh, all these people know this song. This is so crazy.
That is awesome.
Oh gosh.
I know we have a song, but I don't know it. So now I'm thinking, okay, I gotta look up the Utah song.
There you go.
Oh gosh.
They're never like good songs, too. You know what I mean? They were written like a million years ago, and it's probably just some dude's thoughts about the state, you know,
Yeah.
Red
ChatGPT
Rocks
could
and
probably do a better job of at least the current state that states are in now, right?
yeah,
The
yeah, yeah.
because history has changed since many of
Yeah.
those songs were first created and written.
What a beautiful way to say it, Heather. We get to rewrite it based on what
Yeah.
we're seeing right now. Isn't that amazing?
Oh my gosh, absolutely.
Wow.
Angela, are we ready to start?
Life lessons.
Or should
We
we wait a few
are,
more minutes?
let's just give everybody a couple housekeeping notes first. I want everybody
Okay.
to find the chat because that's where we are going to post questions. That's where we're going to put the CE information when we wrap up today. If you have any comments you want to add, go ahead and add those to the chat. Go ahead and scan the QR code while we get started. So, because Katrina's going to give some resources away here. And yeah, Heather, I'll turn it over to you to give our introduction.
Fantastic. Angela, thank you so much. Angela is just the most incredible host. We love having her as our masterclass czar here at Act Dental. She does all those amazing things. Um, Before we get started, I want to share something personal. When I was considering the opportunity to join Act Dental nearly 5 years ago, I reached out to Katrina. And from our very first conversation, I was blown away by her insight, her authenticity, her generosity for taking my call. She had no idea who I was, even though I knew who she was. But she's not one of the most impactful leaders in our industry. She's also an incredible friend to me, and she continues to inspire me daily. Katrina Sanders, RDH, is a dynamic thought leader, educator, and clinical liaison for hygiene excellence and innovation at AZ Perio. With more than 2 decades of experience, she's known for elevating the role of dental hygiene, advancing our understanding as hygienists of the oral systemic connection, and challenging all of us to pursue clinical and personal excellence. She's a celebrated speaker, author, and educator. Katrina's passion is contagious. She blends humor, heart, and high level insight in a way that leaves audiences inspired and ready to take action. It is such an honor to have her with us today. Please join me in welcoming Katrina Sanders.
Oh my gosh, Heather, thank you so much for that amazing introduction. I likewise am so proud of you and all the amazing things that you've done. And it's so fantastic to see you joining one of my favorite families, the Act Dental family. So congrats to you on all of the fabulous things that you've done and will continue to do in your career. And love you, girlfriend. You're just amazing. Hello, friends, and happy Friday. It is so good to see all of you. Thank you for joining me, Katrina Sanders, and the wonderful Act Dental family for this programmatic content. It's so fabulous to have all of you joining us from across the United States. I hope that today's program will give some opportunities for insight in better understanding this monster that we call gingivitis. As a practicing periodontal hygienist, in the perio world, we like to call gingivitis a wolf in sheep's clothing, because quite frankly, for a very long time, a lot of us really viewed gingivitis as certainly not the serious and deeply concerning disease process that it turns out in fact is. When I was in dental hygiene school, I went to hygiene school at the time when we did not have a procedural code available to us in order to treat gingivitis. So perhaps like many of you, if a patient had gingivitis, I was performing a prophy, a D1110. And as we will look at down the road today, because y'all are stuck with me for the next 2 hours, as we look kind of down the road, we're going to learn that prophylactic means prevention. And I don't know, I feel as though in my lizard brain as a dental hygiene student, when I was performing a prophy on a gingivitis patient, the story that I was telling myself is I'm performing this procedure to prevent your gingivitis from moving into periodontitis. However, we now know, and by the way, that's my first pearl to give you. I love sharing this with my patients. We now know, which reminds our patients that dentistry is going to change, it's going to evolve, it's going to grow as we continue to capture really critical data points about how to be more optimized in our care. So we now know that gingivitis itself is, in fact, a disease of the periodontium, albeit it is the reversible form. However, we now know that patients who have gingivitis are not immune to the development of periodontitis. And even more specifically, patients who have gingivitis are not immune to the systemic burden of what having this localized inflammatory disease process is. So I want to begin, and first of all, Angela, thank you. Heather, thank you so much for this introduction. Angela's spot on. I really want this to be an interactive course today. I've got the chat box open here in front of me. I would love to begin by learning from you. So if you wouldn't mind tossing into the chat box, today we're going to be talking about gingivitis and how to treat gingivitis. I'd like to learn or better understand from you, what are the challenges that you are experiencing inside of your practice? This could be working inside of the practice protocol. I don't know what protocol to implement. This could be, I'm having a hard time communicating this with my patients. This could be case acceptance. This could be, well, now we have a new procedural code, and I've got to approach the challenge now of communicating with patients that you're no longer the free cleaning your insurance covered. So I'd like to learn from you, what are some of the challenges that you're experiencing when it comes to treating gingivitis as we currently see it today? Where do those challenges lie? And I ask this because it should seem pretty cut and dry. And the slides that you're going to see over the next couple of hours are going to show that. And yet we also understand that there is an art and a science to what we do in dentistry. And that's really important to understand. Not every single patient is going to fit into a perfect box of diagnostics. And I will tell you, I just got back recently from the American Academy of Periodontology meeting up in Toronto, where, these are the folks that write the AAP staging and grading. And even up there, they said, this is not an exact science. Identifying patients who have these various striations of the disease process, it is not exact. So how do we help better understand and be more definitive in identifying these cases, right? So let's take a look at some of the responses that we're seeing here. And I'm going to capture these because I want to make sure that I'm answering these supportive challenges today. Yeah, it was a bloody prophy. And and that's it, right? A bloody prophy. Um, but when a patient's bleeding, that is the key cardinal sign of inflammation in the mouth. Unfortunately, we don't have anything better yet. Stay tuned. Stay tuned. We're getting there. I mentioned this quite a bit. My sister's a podiatrist. She's a foot and ankle surgeon. And she sees really advanced inflammatory cases. So if she wants to know how much inflammation her patient is experiencing, she'll do a blood sample and she'll measure that blood sample and look for C-reactive proteins and interleukins and tumor necrosis factor alpha and all of those guys, right? That's what my sister does. In dentistry, that is not the current standard. Stay tuned. Stay tuned. Dentistry is evolving. And we've actually seen inflammatory markers added to the grading grid of the AAP staging and grading. So there's a preparation for there eventually being a time in dentistry in which we will be getting some kind of blood sample to identify inflammatory markers for our patients. But yes, it essentially is seen as a bloody prophy. And the bleeding part is the critical aspect of this. That's what indicates to us that these are truly inflamed patients. Patient compliance is another one, and that's really tricky. It's really tricky. As you're going to see in the slides today, one of the challenges of gingivitis is that it is oftentimes painless, which is a good thing for our patients, but a challenge for us because once it's painless, our patients struggle to understand why this is so serious and why we need to do something different. Andrea says, there are hundreds of products to help this disease. What's the best? Oh, girlfriend, you are speaking my language. I get it. There's so much that is out there. And this is, in fact, before we let everybody into the room as a team, we were all talking about this and saying, gosh, there are so many unique products that are out there. And you hear about these products, you'll see programmatic content about these products. Where do we go? And I will tell you, Andrea, and I'm sure many of you are feeling this way, when we approach this disease process, certain hand scalers in your hand are going to be more effective than they will be in my hand, and vice versa. That we all have our own unique experiences as clinicians. Today, I promise to give you the data as I have it because being an evidence-based profession, understanding the science of what it is that we do is really important. And I don't even I don't mean to say this to make people uncomfortable, but I am a provocative contrarian. So it is important to me to share something provocative, even on a Friday morning. Grab a sip of your mimosa if you need to. Right now, the understanding of the scientific method and the importance of the evidence that we in science follow, respect of empirical data, is being questioned. And this is our opportunity as professionals and as advocates for our patients. This is who we are as advocates for our patients. This is our opportunity to share the data as we know it and to make sure that that is what drives us inside of our clinical protocols. We've also got things here like the time crunch. Oh my gosh, it's so hard to explain that need to our patients. And yes, the moment that you have to change course, you've got everything set up. You have planned for that prophy that day. You've got everything set up and ready to go. The moment that things change, now you've got to get up. You've got to go to the front office. You have to speak to your treatment coordinator. Treatment coordinator's got to print out the treatments, got to come back. And by the time all of that happens, time might be up. You may not have the time to perform that procedure. Depending on what your protocol is in your office, your doctor may expect you to perform some kind of a procedure that day. So the patient feels like they got something. So then what if you perform a prophy so that the patient feels like they got something and then you reappoint that patient for that scaling in the presence of gingival? Does that make sense? Stay tuned, folks. We'll talk about all of that today. A lack of education from the patient's perspective, that's huge. And Sabrina, I completely concur. And yet what's so amazing is, I think it was our friends at Listerine that really started this dialogue. They started the dialogue of talking about what gingivitis was during commercials. So the Gen Pop would be watching these commercials and they would say, you know, gingivitis is a very serious disease. And so I think one of the opportunities that we'll have today is to talk about how using the verbiage of you have gingivitis and seeing if that's a trigger for patients, helping them understand what that is can be a critical opportunity. And yes, Angela, you are spot on. How do you tell a patient who's been getting prophies for years that actually we need to do something different? And I will tell you, as much as we believe that we do everything we can in the operatory to talk to our patients about this disease process, patients have terrible memories. So it's important to know. I was just working with our friends at Crest Oral B. They were sharing this study just a couple nights ago. They shared this new study that asked, hey, dentistry, how long do you think it takes a patient to actually purchase the equipment that you tell them they need to purchase in order to care for their mouth at home? So if you told that patient, you need to get a water flosser, you need to get an electric toothbrush, you need to get this, you need to get that, and you tell them that at the hygiene visit, right? Oh, it looks like we're seeing changes in the gum tissues. You need to get this. Like, how long does it take that patient to actually make that purchase? And so we were going back and forth on this, right? So, you know, okay, well, you know, does it take them, you know, we tell them at their prophy visit, you know, maybe it takes them a couple of months. They, you know, write down the name of that product or whatever. Patient comes back in 6 months later. We ask them, hey, I told you about that electric toothbrush, or I told you about that water flosser. You know, did you end up purchasing that? How many times do the patients say, yep, I purchased it and I'm using it, you know? And unfortunately, in this consumer report study, it said it takes a consumer on average 18 months to take your recommendation of the product you told them they needed to have and have them actually purchase it. Which, if you're doing the math on this, if you're seeing your patients every 6 months, that's 3 hygiene visits that patient has to go through before they realize, oh my gosh, maybe I actually do need to purchase this thing that my hygienist or my dentist said I needed. So that's really important as well. You know, I've got some other really great remarks here about, you know, oh, good. Kim says patients are very accepting to treatment. I love that. Kim, we're going to need your secret sauce, girlfriend. Patient compliance and insurance limitations. I'm seeing a lot of insurance usually doesn't pay, and that becomes a financial burden for our patients. So we'll talk about that. Being able to bring our patients back in a timely manner. Many of us are booked out, and I get that. That is really tricky. Wording, how to explain it. And again, that communication becomes really important. We're short on time. There's no question about that. So how do you move through that in a way that helps support patients? I love this. Brittany says my office doesn't contract with any insurances. Oh, yes, I love that. So we don't have to worry about insurance not paying for it, which is a great game changer. Yes, I get it. I've worked in many fee-for-service practices, and it is nice to be able to have the autonomy to decide outside of the confines of insurance for sure. My office won't implement, even though I've been talking about it. Oh, they think it's too much work or that insurance will deny. I'm frustrated. I would be frustrated too. I'm turning the prophy mill around slowly but surely. You know what? Thank you for what you're doing, Heather, for your patients. That is really critical. And yes, Carrie, you hit the nail on the head. If the patient home care doesn't improve, then what are you doing? Just constantly doing that D4346? Yes, that's absolutely correct. Yeah, insurance denials I'm seeing quite commonly here. Good things are coming out of this, like doing biofilm samples chairside to actually show the patient. Yes, it is a time vacuum. There's no question about it, but helping the patients confront their disease becomes really important. It's really terrific. I think this is an opportunity for us now as clinicians to identify and honor those challenges for what they are, because these are the challenges that get in the way when you're in the clinical op. And I will tell you, I am still a practicing hygienist. When you are in that op and you are, treating patients and you're moving through day to day, this can in fact be challenging. It can be hard to overcome these challenges. And so my hope is that in our time together today, that we have the opportunity to really look at the extent of where these challenges show up and identify ways to overcome them here together, so that when you return to that op Monday morning, that you have some tools in your tool belt to be able to achieve that. Well, my name is Katrina Sanders, and I am here as a contracted speaker alongside the amazing folks of ACT Dental University. So thank you guys so much for inviting me to be a part of this conversation. It is an honor to be here. I will be sharing some programmatic content from receipt of educational grants from our friends at Close, BioGaia, Septidont, Ivoclar, and PerioProtect. First and foremost, and entirely, I am a practicing dental hygienist. I'm a wet-fingered clinician. I work with AZ Perio. We are the country's largest group periosurgical practice. And as a periodontal hygienist, I believe that I've had a very intimate relationship with all different kinds of inflammatory conditions. And so I will be leveraging and utilizing some of the protocols that we use in our practice to help clarify how we address this disease process. Today, we will be looking through some of the key clinical manifestations of gingivitis, and particularly how we implement those manifestations into our diagnostics. It's important that we know what we're looking for first. If we don't know what we're looking for, we're going to run into challenges. So we want to be able to know what it is that we're looking for, have the antenna up, and subsequently from there, as many of you shared in the chat box, we need to talk about what that implementation looks like. How do we find the time? How do we address this? How can we prepare up front? And more specifically, how do we employ communication strategies to help our patients fully understand? So I'm going to be kind of walking through each of these one by one, but you're going to see throughout the course that I'm going to be tossing some important communication pearls. And please also know that chat box I've continually got open. So if you've got questions along the way, please do let me know. I know Heather will interrupt me and ask any questions that are necessary as we drive this along. So let's keep this a fun peer-to-peer conversation. It's Friday morning. We're talking about gum disease, friends. Let's keep it fun. So with that, let's dive in to really kind of taking a step back and understanding what it is that we know about gingivitis. Sorry, friends, I'm super pregnant, so I'm chugging water like crazy. All right, so gingivitis, we know, is actually considered the most common form of periodontal disease. Yes, it is in fact a disease of the periodontium. And that's really important, albeit it is reversible in nature. Spoiler alert, we know it is reversible in nature. It still is considered a disease of the periodontium. And because we understand that, because we now know that gingivitis is in fact an actual disease, it now means that we need to be doing things to actually treat that disease. And that's where we need to start to drive our implementation. I do believe one of the challenges that we have is it is so frequent, it is so prevalent that we almost become accustomed to seeing it all the time, that now we have to kind of change the way we approach our patient communication strategies so as to say to our patients on a more routine basis, there is an activity of the disease process going on here. There is an activity of the disease. The good news is we caught it early. The good news is we caught it in a reversible state. Here's your communication pearl. We now know, right? Here's your second communication pearl. The good news is we caught it early. With effective treatment in office and partnership with your work at home, we can reverse this. If we cannot effectively eradicate this disease in office, and or we can't control the inflammatory process with you at home, it's not a matter of if, it's a matter of when that disease process will accelerate into something that is no longer reversible. And at that point, I think it's important for patients to recognize that they're not powerless in this, that we're going to do things here, but we need your partnership at home. And so that's where I really stress with patients. We've got these two critical confounding factors. We've got to do the work in office. So if you say no, if you say no, and we're going to do a bloody bib prophy, be prepared. This is not going to get better. That's informed consent 101. Informed consent 101 is letting the patient know the risks of not proceeding forward with treatment, right? But the second part is you do have power in this, and that will be the work that you will do at home. Here's Dr. Spitz, my favorite Boston doctor. Dr. Spitz says, I'm speaking to the hygiene students at Forsyth Hygiene School. Thank you so much, Doc, for doing that. Love you. What top 3 things you think I should stress to new hygienists about to graduate from school? Gosh, you know what? I want to actually have hygienists toss into the chat box. What are some things that you think Dr. Spitz should share with brand new hygiene students about to enter the profession? So brand new hygienists about ready to enter the workforce. What are some things that you think he should share? I think it's important for us as professionals to always begin by welcoming brand new grads into the profession, number one. So that's always the first thing that I say. I work with dental hygiene students as well. And I always say, welcome to the profession. It's an amazing profession. You will receive what you put into it. There's no question about that. So I think that's number one. Number two, I think it's really important to remind them that they have their own ethical principles and they have their own autonomy as clinicians. And there are times when you may be put into an employment situation where your ethical principles will come into question, where you will be expected to do something unethical. And know that you, at the end of the day, have to put your head on that pillow at night, know that you did the right thing. And the third thing I would say is don't be afraid of your patients, because patients are already afraid of us. We shouldn't be afraid of our patients. Be honest with them. You're not here to be their friend. You're not here to, yes, we want to know about how the, family vacation was in Hawaii and how cheerleading camp is going for the kiddos and all those things. But first and foremost, we are here to deliver care to our patient community. Don't be afraid to let them know. And I think this, even this chat box here is a good example of practicing clinicians who are saying, like, I know what this disease is. I know how to treat it. I got insurance. I've got, maybe my office manager or doctor practice owner not supporting me. We heard today, I'm trying to turn the prophy mill and get us into something different and something better. Don't be afraid of your patients. Let them know this is the disease as we see it. And this is an opportunity for us to educate them. Because the reality is the average primary care physician gets 9 minutes and 36 seconds per patient to do a head to toe exam of that patient. That's a PCP. We have a significant amount more time. I know we never have enough time. I get it. Every dental professional in the country says we don't have enough time. I get it. We don't. But the reality is, compared to our medical colleagues, we do. And we are so well positioned to talk about prevention, inflammatory diseases, the oral systemic link, nutritional counseling, tobacco cessation, lifestyle changes. So we have an amazing opportunity to really advocate for our patients. But that means that we have to be prepared to advocate for them. Yeah. I'm loving some of the things that are popping up here in the chat box as well. Oh, learn the codes. Yeah, exactly. We are licensed professionals. Stand strong in our clinical judgment. I love that. Some really great answers there. Back to gingivitis. We know most frequently the most common variant of gingivitis is your plaque induced, which means that a lot of the work that we do with our patients is going to be really designed around biofilm control. Not always, but a significant portion of the time. Biofilm control is going to be our number one goal. It is more prevalent in our male demographic. Statistically, no unkindness or offense intended toward our men joining us today, but statistically, we believe that this is because women are a bit more prudent with their oral hygiene care regimes. So we believe it's not necessarily that you are a male, but just that women are a little bit more cognizant of their oral hygiene practices. We do see it in children and in adults. And I think this is another really important talk track. Making sure that when we're educating our patients, albeit I work in a perio office, so the pediatric demographic is not one that I commonly see unless it is extremely severe. But it is important to let our patients understand, our parents understand, just like childhood caries is a disease process, childhood gingivitis is a disease process, and it is extremely prevalent. And unfortunately, we do know that it's more prevalent in individuals of a lower, more vulnerable socioeconomic status. And unfortunately, we see that likely due to, improved oral hygiene and better access to care options in a more affluent patient population. Lower socioeconomic status individuals typically do not have access to the same accoutrements of oral hygiene aids, access to healthcare, and now, just speaking frankly, even access to healthy, nutritious foods, which we're starting to understand that nutrition is a critical factor in the inflammatory process as well. So this becomes a really important aspect for us to consider. Now, it's important for us to really make sure that we know how to differentiate between gingivitis and periodontitis. Gingivitis, again, certainly being a disease process of the periodontium, it's important for us to make sure that we know where is that line in the sand. And I will tell you that line in the sand is the CEJ. Gingivitis, we know, is an inflammatory condition, not unlike periodontitis. The major differentiator between gingivitis and periodontitis is the fact that in gingivitis, there is no attachment loss. I cannot stress that enough. There is no clinical attachment loss. So the attachment apparatus in gingivitis will come straight up to that CEJ, and then you will see inflammatory processes. Could you see advanced probing depths in these cases? Of course. But those advanced probing depths are not because of deepening of the pocket, but rather because of hyperplastic, pseudo-pocketing, or enlarged tissue. So it is important to know that the line in the sand when it comes to gingivitis and periodontitis is literally defined by that CEJ. Once you can take an 1112 ODU Explorer and explore that root surface and detect the CEJ and or cementum, you know that there has been broken clinical attachment around that CEJ, and that's what creates a key critical challenge there. And in fact, I just recently wrote an article in RDH Magazine. I don't know if my husband is still on listening, but Dale, if you are, if you wouldn't mind tossing into the chat box the link for that article to my clinical attachment level article that I wrote for RDH Mag. This, I think, it's the first of a 3-part series of an article that really is talking through better understanding what is considered a stable clinical attachment level, what is considered unstable. So the inflammatory process begins as gingivitis. It is restricted to the soft tissue area. The tissue is the issue. I cannot say that enough. The tissue is the issue. That's going to be important. Because when we talk about differentiating a gingivitis therapy from a prophylaxis, we know that a prophylaxis is the removal of plaque retentive factors. These are localized factors that are, creating or could potentially create issues. Once we get into the activity of gingivitis, now the story is different. Now the story is different. Now we have a disease process restricted to that soft tissue, which means, yes, we're going to need to do some kind of a debridement. We have to remove the hard and soft debris that is creating that inflammatory process. There's no question about that. Thank you, Heather, for tossing that article in. I so appreciate it. If y'all check in the chat box there, that's part one of a three-part series. Yes, it took us 3 parts to write this article, but really great data in there, great images, great tables, and things like that. So that's your gingivitis. If the gingivitis does not resolve, we know that the inflammatory process that is in the soft tissue and underlying connective tissue or lamina propria will subsequently create a breakdown of that clinical attachment. That's where we start to see movement from the attachment being at the CEJ downward. The definition of periodontitis is apical migration of the junctional epithelium, right? That's the major differentiator here. Apical migration of that junctional epithelium. And of course, along with it, bone loss will happen eventually. But bone loss is not the definition of periodontitis. It is apical migration of that junctional epithelium. So it's important to know when we take a look at our patient demographic here, that we need to draw that line in the sand. Now, I'm seeing a notation here that says 1 to 2 millimeters below the CEJ is normal. 3+ is perio-SRP. So 1 to 2 millimeters of the bone level being below the CEJ is normal because we permit an attachment apparatus around the CEJ of about 1 to 2 millimeters. That's considered the biological width, right? So the bone level will be about 2 millimeters from the CEJ. Bone level will. But the clinical attachment, the soft tissue attachment, should anchor directly into that CEJ. And I want to make sure that that is well notated. Soft tissue attachment and bone level are different. We know that to be the case, right? Soft tissue attachment, bone level. Bone level will be about 1 to 2 millimeters from that CEJ. That's still considered a healthy attachment, bone level. But the clinical attachment should anchor into that CEJ. Okay. So this is where the challenge really lies. Gingivitis has historically been seen as a subclinical observation. Subclinical meaning that it's suspected that there's a disease process. We've got a pile of gauze on the corner of our tray that is covered in blood from our patients. But we don't we haven't convinced ourselves that the disease process has accelerated or developed enough to be definitive. That's what a subclinical observation is. And I think that's a perfect definition of gingivitis. Yeah, we see bleeding. Yeah, we see biofilm. Yeah, we see redness. I mean, when does it get to the point where it is detectable and it is giving us such pervasive effect to the patient that now we need to go, yep, we need to move forward. We need to do something different. Therein lies the challenge. Another challenge is this within normal limits perio stamp pad. So for the Gen Zers out there, stamp pads are what we would use on paper charts before we got electronic charts. And this is, of course, a little bit of a farce or a joke. But unfortunately, we see all too commonly, and I, as a clinician who does help with coaching around perio complications, I see this quite a bit. The complication of every patient just being a 323. So perio charting's been done, or rather spot charting has been done, and a clinician just went 323, 323, 323, 323 into the software so that a chart reflects, so that an office manager or a treatment coordinator can go into the chart and say, okay, this is what I'm seeing. a perio chart was done. However, it may in fact not be accurate. That we will see pseudopocketing or enlargement in some cases with gingivitis. We could also see bleeding tendency and separation. And if those things are not notated in our periodontal charting software, unfortunately, we don't have an accurate chart, which means we may not be seeing what it is that we need to see. So therein lies part of the challenge. The truth of the matter is that gingivitis dynamically impacts a significant portion of our patient demographic, over 90% of the population. And it's important to know that one of the most critical of the parameters in identifying this disease process is detected and documented by bleeding upon some kind of stimulation, most oftentimes probing. But it doesn't have to be probing. It can be bleeding upon stimulation. So I get patients sometimes who will say to me things like, well, yeah, of course I'm bleeding. It's because you stabbed me in the mouth skin with a tiny little sword. That's my probe, right? And so a few things to let our patients know. Healthy tissue, when struck, shouldn't bleed. It should be really resilient. We also know that sulcular epithelium is friable, right? So I always like to say, kind of like our hand, we've got this keratinized tissue here. This is really protective, right? Keratinized on the palm of our hand, but on the back of our hand, less keratinization, and so it is more vulnerable. Which means that if there's bacteria sticking in that area, it is a lot easier for that bacteria to break open that epithelium. That's what happens in that little, gingival pocket or periodontal pocket or that sulcus, right? That's what we're concerned about. So in order to achieve periodontal stability, we need to make sure that we are treating the areas that have persistent bleeding upon probing, because that tells us that something is wrong, something is broken around that epithelium. If a patient has suboptimal probe depths, it shouldn't be lost on us, number one, that means that we're going to start to see an evolution of the bacteria in that area. So as we get deeper and deeper into those probe depths, this is where we're going to see the maturation of that subgingival biofilm. That's where we'll see things like the movement from your gram-positive aerobic bacteria into gram-negative anaerobic bacteria. And it's important to know as well that suboptimal probe depths are nearly impossible for our patients at home to take care of, right? So that becomes the complication as well. It's important to know that our goal, and I let my patients know this. So here's our third pearl. I have people asking questions about, do I have a list of my communication strat? I don't. I'll write a book someday. I'm gonna get that all out there. But for right now, definitely pen and paper, friends. Write these guys down. These might be helpful. So here's pearl number 3. Pearl number 3 that I let my patients know is, my goal for you is to get your mouth to a place where you can maintain it at home. That's my goal. Because if you can maintain it at home, then we're cool. My expectation is that you're going to buy the electric toothbrush or the water flosser or do the interdental, whatever those things are. That's my expectation. But my goal is to get you to a place where you can maintain this at home. That signals something to the patient. I hope you all wrote that down, by the way. That signals something to the patient. It tells the patient right now, you can't maintain this. And that's important, because if your patients are anything like mine, the first thing that they're going to think is, oh, I have this disease. I haven't been flossing, so I'm just going to go home and floss better. And they may even try to tell you that, right? Well, what if I just flossed better? What if I actually bought that electric toothbrush you've been telling me for 18 months to buy, right? So it changes that narrative for our patients. And it helps them understand right now, this is not maintainable. Right now, you cannot maintain this. We know that to be true. You can't get to the base of a 4 millimeter probe depth. You can't. So we need to make sure that we're doing the things here to get you to a place where you can maintain that at home. That's my goal. And that should be a reasonable goal, right? Let's talk about some of the clinical manifestations. of gingivitis. And in the resource that I provided, we're going to take a look at some of these modalities together, but in the resource that I provided to you, these are included as a part of my suggested narrative for you. So clinically, we will see things like swelling of the gingiva, we'll see redness or erythema. The gingiva might be tender. So it might not be tender for the patient because the patient at home isn't brushing and flossing the way we told them to. There was a study that was done at the University of Minnesota. It was replicated by our friends at Crest Oral B that gave patients a toothbrush and said, brush for what you think is appropriate amount of time to brush your teeth. And the average was anywhere between 37 to 42 seconds is how much the average patient brushed. And the average patient, by the way, brushes one time a day. It's important to know that these average statistics are what's showing up in our office every day. We don't have data on flossing because even if we did have data on flossing, we would know our patients are lying, right? Let's hope they're lying through their teeth. So something's getting through there because floss isn't. So unfortunately, that tenderness may show up because although performing self-care at home may not create that tenderness in the office when we're articulating against ulcerated sulcular epithelium could be an issue. Shininess, and that shininess is, certainly, created from the concept of a loss of stippling. We're starting to see enlargement from edematous fluids, which starts to make the gingiva, as one of my periodontists lovingly says, kind of like the outside of a, red tomato. And so because of that shininess, meaning that there's edematous fluid on the inside. We also can see bleeding upon gentle probing. At the early stages, it's not necessarily that bleeding is spontaneous, so it could be delayed. Oftentimes, we can see that not necessarily when we're probing the patient, but it could also be when we're starting to scale the patient, right? So you might polish the patient, or you might, for example, have use an interdental aid, right? And that creates the disruption of that biofilm just enough that we're going to get that delayed bleeding. And again, it's important to note as well that this is quite commonly a painless disease process. So patients may not recognize that it's a problem. It's something that becomes detected inside of the office. A few things that we want to focus on when it comes to patient assessments. So the key points for us to consider, or a few questions that I like to ask, and I ask these out loud in front of the patient in some cases, or rather, we're having these discussions chairside. So, okay, we're looking at these assessments. A few things, Mr. Jones, that I'm looking for. I want to know, is there bleeding during my assessment? Mr. Jones, me just doing an assessment of your gums should not cause bleeding. I need to tell Mr. Jones what normal is. Normal, or rather healthy, is your gums should not be bleeding. If I'm getting bleeding during your assessment, that's a problem. One of the other things that I'm going to be looking for, Mr. Jones, is there bleeding that has been persistent? So, oh, I'm getting bleeding today. Let me look back and see, is this something that we saw last time? My goodness, it is something that we had seen last time. So what we did last time was a regular cleaning that your insurance covers. And because that bleeding is still showing up today, it's telling me that a regular cleaning that your insurance covers is probably not going to be a good endpoint solution for you. I'm starting to kind of front load for the patient or help them understand. If you think you're getting a free cleaning, unfortunately, what we've been doing is no longer working for you. A few other things that I like to ask the patient, or rather ask myself in front of the patient, is, has that probe depth progressed? So this is where I might say, you know what? You've been a patient of our office for 7 years. Let me look back. I want to see when you first came in, what did that pocket look like? Right? I here in Arizona, A lot of us, particularly those of us who are very white-skinned, spend a lot of time at the dermatologist. Uh, my dermatologist will do that. Let's look back at what that looked like when you first came in as a patient of ours 7 years ago, because I want to see, has that moved? Was it nothing? And then all of a sudden, 7 years later, it's something? Because if so, then we need to do something about it. That's what healthcare does. Healthcare 101. This is what your blood pressure looked like when you came in 7 years ago. Here's what your blood pressure looks like today. It looks like we're watching this disease process continue to accelerate, right? So have these probe depths progressed? And then the question I want to ask myself is, can you, patient at home, maintain those probing depths? So that becomes really important as well. Is there an opportunity for my patient to be able to deliver that self-care? If they can't, if they cannot maintain those probe depths, then it's important that I tell my patient that, because I'm going to set my patient up for failure. I'm going to perform a prophy hoping that that's going to be enough and send my patient out for 6 months to allow them to not be able to effectively maintain their oral health. Are there localized factors that can influence plaque retention? And more importantly, in the past, have we seen those sites respond previously? Again, if we've been performing prophies, have those sites responded to a prophy? If they have, great, then maybe we can continue doing a prophy on these cases. But more often than not, the sites have not responded well to previous therapy. And this is where I think we really need to think through what are the next step opportunities here. Okay. So this, by the way, comes from the ADA. I have to disclose, I did used to have a license with the ADA to deliver code-specific programmatic content. I have let that license lapse. So I do need to call that out. This is simply a image directly from the ADA, from their code of ethics on the 4346 guide. And a few important things that I do just want to call out that the ADA indicates here in this imaging. So a few things. Number one, there's no age limit. You can see that we've got a kiddo here in braces. So there's no age limit there. One important piece that we are in fact looking for is stability of bone and no clinical attachment loss, as you can see here. Another compelling piece that I want to call out that you'll start to see here is the concept or fact that the evidence that's being submitted for this case is a combination of both radiographs showing stable bone level, as well as a photograph, as you can see down in this, we'll call this the lower left quadrant, the lower left area here, where you're seeing that redness or that bleeding, which is a compelling way of showing the patient and potential third-party payers what the inflammatory process looks like. In the resource that I provided, I gave you a narrative. So yes, this is not a comprehensive resource. This is a resource to give you specifically the narrative. Feel free, if there's anything that you found of value in the programmatic content I'm presenting, to write that down. Feel free to grab screenshots of anything that you would like. But the narrative that I provided to you gives you an opportunity to describe to a third-party payer how you see the disease process, but showing the photo of the disease process becomes really critical. A few things, and again, this comes directly from the ADA, so I don't own this. This comes from the ADA, really clarifies how you apply very specific findings. So they describe the gingiva, and then they describe the attachment apparatus and the bone level. In a generally healthy gingiva situation, if there is inflammation, it's just in a few localized areas. Where the attachment is healthy, there's no clinical attachment loss, there's no bone loss, it would make sense to proceed with a prophy. Notate that if the gingiva is experiencing generalized inflammation, and you could describe that inflammation as moderate to severe, keep in mind, again, the attachment is healthy. There is no attachment loss, no bone loss. This is where you may want to proceed forward. with a patient that, for example, would be appropriate in this gingival scaling procedure. Let's say the patient has localized inflammation and localized bone loss. This is where the recommendation would be, well, if it's localized, you may need to perform either that SRP in the 4+ or 1-3 in those localized areas, and then performing a prophy elsewhere. Versus if the patient has generalized inflammation, this is where it gets tricky. If the patient has generalized inflammation and the bone loss is localized or generalized, you'll see here, you would perform scaling and root planing in the areas where that bone loss is occurring, whether that be localized or generalized, and also a prophy in the other areas here. So that becomes really critical. Carrie asks here, we've gotten 4346 denials for the lack of bone loss. That is pretty compelling. Carrie, if you're submitting a 4346 in a patient that doesn't have bone loss, you are doing it correctly. So unfortunately, this may be a situation of, and I will tell you, I get a lot of questions about insurance. I think we can all agree as dental professionals, there are hundreds of companies, thousands of plans that are out there, right? Thousands. So it's really hard to, predict what Susie Q from Blue Cross Blue Shield of blah, blah, blah is going to do in this plan that was negotiated by the HR department of this company, et cetera, right? That becomes really challenging. What we can do, and Carrie, this would be my suggestion to you, is to leverage the use of the verbiage as it's laid out in the CDT handbook from the ADA. And I would send that back in a rebuttal letter to that third party payer. When would we integrate gingival scaling for our patients? We would integrate it once an exam has been fully performed. So this is not like the full mouth debridement where you don't do an exam. You need to have comprehensive assessments. So that exam needs to be performed. The patient needs to be diagnosed with generalized moderate or severe gingivitis. The patient could have pocket depths. Now, this is not a hard rule. They could have 1-3, but if they do have 4 mm pocket depths, those 4 mm pocket depths are because of pseudopocketing or gingival enlargement. It is not because of apical migration of the junctional epithelium. They should have moderate to severe bleeding upon probing. And Carrie, again, to your point, radiographs show that there is no bone loss. You would not perform this procedure if the patient was diagnosed with a classification of periodontitis, if the disease is only localized or slight, if the bleeding is only localized, if there's attachment loss, if the radiographs show bone loss, or if there's too much plaque or calculus for an exam to effectively be done. So that becomes really critical. The ADA describes this, because it's in the 4000s, as a periodontal procedure. It is therapeutic in nature, and it is intended to be delivered to a patient who is in a diseased state, in an individual who has swollen, inflamed gingiva, generalized supra bony pockets, and moderate to severe bleeding upon probing. So you're going to see, for those of you who have captured the resource, that the narrative that is kind of laid out indicates or leverages a lot of this verbiage, that narrative being important in your clinical notes, and then, of course, an opportunity for submission to a third-party payer. When a patient is diagnosed with generalized gingivitis following a comprehensive exam, that procedure, the scaling in the presence of gingival inflammation, should address that gingival inflammation and the pseudopocketing that's present. Let's take a look at the critical assessments that we should be capturing. So during that gingival therapy appointment, here are some of the assessments that we capture. And I want to share this because some of these are going to be the obvious identifiers. Yes, we should be getting perio assessments. We should be probing the patient. We should be evaluating bleeding tendency. We should be looking at observations of the gingiva. We should be looking for, bone height levels and confirming that bone height level radiographically. We could be doing some of those things. And in fact, some of you have even said we get a biofilm sample, we do clavicular fluid testing, we do salivary diagnostic testing, etc. So this is the first place to start. But it's also important to know that there are other important indicators that point to inflammation being present for the patient. And these are also things that we should be documenting. Those could be medical history identifiers. That could be dental history. That could also be looking at plaque retentive factors. Consider things like bands and brackets, an overhang margin, restorations that invade the biologic width. It could even be a patient who's got an allergy to the metal substructure of a PFM, things like that, right? Those could all be plaque retentive in nature. Social history, the patient's diet. I have a podcast, a mini series that I do each month called Ask the Expert. And in October, my Ask the Expert episode was on a research study that was done where patients were they were put onto kind of a remote, it was like kind of like survivor style, right? They were isolated. They weren't given any oral hygiene aids whatsoever. However, they were put on a kind of a Paleolithic diet. So no refined sugars whatsoever. They were consuming seeds and turmeric roots and things like that for 4 full weeks. And whereas you'd expect, because they weren't performing debridement of the teeth, you would expect that they would have a lot of inflammation. In fact, they didn't. Their glucose levels were very low. And because of that, we didn't see a lot of inflammation in the mouth. And so there's some really compelling data out there about how important diet is to the inflammatory process, what their habits are, etc. And then looking at things even like intraoral scannings that can kind of map out the architecture of that gingival enlargement. So that becomes really important. Again, when we're performing clinical assessments, an appropriate gingival scaling patient should have probe depths, bleeding notated, whether that is delayed, pinpoint, spontaneous. They could have pus. There should be an observation of enlargement of the contouring of that tissue, changes in the color of the tissue, changes in the consistency or texture of the tissue. We would be observing deposit levels, so various types of plaque, calculus, food impactions, materia alba, plaque retentive factors. And we would also want to denote medical conditions that could influence the quality of that gingiva. Things that should not be included would be recession because the patient has a history of perio, furcation involvements that indicates clinical attachment loss, mobility of teeth, or bleeding that is not put in the perio chart, it's only put in our narrative. Those are really important modalities to consider. And again, when it comes to assessing, now we're walking through ADPI here, those assessments become really important. The moment we find furcations, the moment we start to see recession because of a history of perio, we're no longer talking about gingivitis. And again, on the diagnosis side, it is important to note that a significant portion of gingivitis cases that we're going to see is biofilm induced, your biofilm induced gingivitis cases. So in a biofilm induced case, the presence of biofilm is the contributory factor. And that biofilm in combination with other contributory factors can accelerate that gingivitis. So we can have patients that can have, sex steroid hormones. So puberty induced gingivitis, menstrual cycle induced gingivitis. I'm 35 weeks pregnant. And yes, I'm not proud to say, but I've experienced some pregnancy gingivitis, oral contraceptives, hyperglycemics, leukemias, tobacco habits, malnourishment, various kinds of oral contributory factors or drug-induced gingival enlargement. So we can see biofilm-induced, and that's the most common that we see. There is another category of gingivitis that's out there, and I want to share, folks, I typically do a course like this in like a full day workshop. So I'm whittling this down into like 2 hours to make sure that we really hit what is important. There are non-biofilm induced gingivitis cases where there will be inflammation in the mouth, but that inflammation is not because of biofilm. And that's really tricky because in dentistry, have you ever heard that term? Like if all you have in your hand is a hammer, then everything looks like a nail, right? So that's really tricky because we've been given hammers. We have been given hammers, right? And those hammers are plaque debridement aids or hand scalers, etc., right? So when we are constantly taught that our best tool is a hammer and everything looks like a nail, we want everything to be biofilm induced. And the concept here being that there are a significant portion of times when you will debride the patient, you'll do biofilm control, and the patient will still not resolve. That becomes really important because if the patient doesn't resolve, there's a potential that that gingivitis was due to something else, some kind of viral issue, some kind of fungal issue, a neoplasm, some kind of an inflammatory or immunocompromised response, a genetic or a developmental disorder. So one of the important things that we're going to look at in the workflow of how we execute this is how do we execute this and also make sure that we're evaluating our patient. If we can execute an effective biofilm debridement system and we can then reevaluate and determine, were we successful? If the answer is no, and we've done a good job of biofilm debridement, that now gives us an opportunity, I think, to question, is there something else that's going on in this case? Now, I've got a really good question in the chat box here from Claudia. Thank you for this question. This is the question everybody wants to know, right? What if the recession is due to bruxism? Can there be clinical attachment loss in the mouth due to things other than perio? And the answer is yes, there can be. If that is the case, we have to be very crystal clear in our clinical notes that if the patient has clinical attachment loss, that clinical attachment loss is due to some other iatrogenic factor. And it is our responsibility to determine what that is. Did the patient have a tongue ring that rubbed down on the lower anteriors, and that's why they have recession? Did the patient have a bruxism habit? Do they go through rounds of ortho where their mandibular molars are linguoverted, and so they do have some exposure, hypereruption, things like that, right? So if that is the case, we need to call that out. We need to call that out so that it doesn't throw us off into thinking, well, there is clinical attack. The first thing, certainly, that a third-party payer is going to assume when you're talking about scaling in the presence of gingival inflammation is that recession is because of periodontitis. Now, if you're billing out a periodontitis treatment, your third-party payer might think something different. They're for-profit institutions, folks. That's what these third-party payers are. So they do make, unfortunately, a profit if they find a way to deny your claim. Okay, let's take a look at this narrative. And the piece that I really want to share with you inside of this narrative, and again, this is what was distributed to you, is where are the fill in the blank opportunities, okay? So you've got your medical history here. This is where you're going to insert what are the key contributory factors that could indicate that there is inflammation occurring. And that may also include medications, right? Are there medical conditions and or medications that will create that inflammatory process? Then you want to make sure that you're calling out gingival observation, clinical observations of the gingiva. So talk about the enlargement. Is enlargement there? Is the enlargement even causing pseudopocketing, right? What's the color of the gingiva? Now you've got to get out your bag of tricks and, capture all of those opportunities with various types of colors. What is the contour? Does the interdental papilla become bulbous and, overfill the space? What is the consistency? Is it smooth? Is it stippled? How is it, performing when you're probing it? Take a look at the observation of deposit level. Is there generalized hard deposit, generalized soft deposit, generalized materia alba? Are there food impaction areas? Then you capture an assessment of your periodontal condition. And this is really a descriptor from the periodontal charting. So what is that probing depth range? Is there bleeding upon probing that's been observed? And if so, what percentage of the mouth is bleeding? That you should be able to capture from your clinical assessments. And you do want to make a notation, no clinical attachment loss or radiologic bone loss detected. Now, in the case that Claudia shared, you could say clinical attachment loss noted on number 28 due to linguoversion, history of ortho, and subsequent bruxism. So now you're calling out why there's only localized clinical attachment loss in that area. Again, what I want you to see is that this statement here is borrowed from the CDT book, the ADA book. Patient presents with swollen, inflamed gingiva, generalized suprabony pockets, and moderate to severe bleeding on probing, right? The diagnosis you're going to put in, so you want to make sure that you have a diagnosis, and now you're going to insert those key contributory factors, right? What are those contributory factors? Is it tobacco habit? Is it diet? Is it poor oral hygiene? Is it, dexterity? What are the contributory factors in this case? Those contributory factors we need to make sure we're addressing. And then we talk about that warranted treatment, scaling in the presence of gingival inflammation. We're going to do some soft tissue management modalities. We'll talk about some of those options toward the end of our program today. And then patient counseling. What kind of counseling did we do? Did we do tobacco cessation, nutrition, oral hygiene? What kind of counseling did we do? So I want to give an example of a patient, right? Here's the proverbial patient, Chris, who's been a patient of record in our practice for 5 or more years. He's got some findings on that medical history, right? He's hypertensive. He's taking atenolol. He's got a family history of some inflammatory conditions. So, cardiovascular issues is going to be a concern for a patient like this. He also works emergency services and he works at night. He's noticed some weight gain and his diet is inconsistent. So right out the gate, before we even dive into his oral health condition, we know that there are some contributory factors here that could be contributing to an inflammatory process. Had a neck exam. He's got some findings here. He's got an observation called Frank sign, which is a diagonal crease in the ear. If the patient has that, they've got an elevated risk for 78% elevated risk for experiencing cardiovascular issues. And then Fordyce granules. Fordyce granules are fatty deposits across the tissue, a pretty good indicator that patient may have high cholesterol. Okay. Patient's been coming in every 6 to 8 months for prophy procedures. Today, he's got 4 millimeter probe depths with moderate bleeding tendency. 55% of the mouth is bleeding. Previously, he was within normal limits. So whether that was correct charting, we don't know. But today he presents with new findings, and we think that that might be due to declined oral hygiene routine, which he has shared. So previously, he looked like this. Today, he looks like this. So this is where your charting becomes really compelling and where imaging is going to become really compelling as well. An example of a clinical narrative that we would want to include for a patient like Chris would be notated here. Again, this is an example of how we would fill this out. So we would say, okay, on the medical history, he's got a new condition of hypertension and he's taking atenolol. And by the way, that atenolol isn't doing an amazing job of treating his elevated blood pressure. He's got a familial history of inflammatory conditions. Lifestyle wise, he works at night, which we know is a contributory factor to systemic inflammation. He's got an inconsistent diet, and he admits a decline in oral hygiene practices. From a clinical observation, we noticed moderate enlargement, redness, enlarged interdental papilla, and enlargement of those gingival margins. He's got moderate biofilm and localized grainy calculus sites. On those probe depth areas, we're going to describe them as generalized 3 to 4 millimeters, but that's gingival enlargement of those probe depths. He's got a 55% delayed bleeding index. So delayed bleeding again means he could get bleeding not just from bleeding upon probing. That could be other things. That could be things like, we used an interdental aid and we got some bleeding. It could be we, began doing just a pre-procedural polish and the patient started bleeding. No separation, no clinical attachment loss or radiologic bone loss. And again, here's that narrative borrowed from the ADA about the actual procedure itself. Patient presents with swollen, inflamed gingiva, generalized suprabony pockets, and moderate to severe bleeding on probing. Here's his diagnosis: chronic, generalized, moderate, biofilm-induced gingivitis. That's his diagnosis. And the contributory factors are declined oral hygiene, inconsistent diet, and medical conditions. Finally, we want to make sure that we include what are the warranted condition, or rather warranted treatments to address that condition. That's where we would talk about scaling in the presence of gingival inflammation, soft tissue management, oral hygiene, and nutritional counseling. And again, we'll talk about what those modalities are in literally like 2 seconds. Give me one more slide, and then I promise, friends, we're going to walk through that implementation. Okay. I just want to conclude on the paperwork side, and then we're going to dive into patient care, folks, because we have to get there. On the patient paperwork side, you want to make sure that you are including perio charting that records that pseudopocketing and bleeding. And that becomes really important. There should not be clinical attachment loss. There are going to be a few exceptions to that. And if there are, we talked about the fact that you would want to call that out in your narrative. Yes, there is clinical attachment loss. That clinical attachment loss is due to insert reason why, but perio not being that reason, right? And then you want diagnostic images. Your doctor will be the one to really determine and diagnose what that is. It should be radiographs that do not show bone loss. It should also be either extraoral, retracted, as we saw with Chris here, extraoral, or grab your intraoral camera and snap images with that intraoral camera showing the condition of the gingiva, right? Showing that condition. All right, friends. So we've talked about what this disease process looks like. We've talked about the paperwork around it. How do you implement this, right? Or rather, how do you identify if you need to implement it? The remainder of our time today, we're going to talk about the implementation process. What does that look like? You see a patient who does in fact have this disease, and now you want to move forward with it. And I think it's really important. Somebody said it earlier in the chat box, and like you were speaking my language. I can't remember who it was who said it, that this is really hard. It's hard to differentiate this procedure from a prophy. And that is true. We're performing debridement. We're going to perform mechanical instrumentation, for example. We are going to use, or rather we should be using, a combination of mechanized scaling and hand instrumentation. And while the data here being presented is about scaling and root planing, it is important to note that even something invasive like scaling and root planing does not demonstrate sufficient data that one session alone is enough to shift that patient into a healthy microflora. So our instrumentation is important and being able to debride the patient is important, but other modalities are going to become critical to the story. So yes, implementation wise, it might to the patient feel like this is the same treatment that they had done as their regular prophy. And that would be if we maintained the same workflow. Remember, when we're talking about gingivitis patients, gingivally diseased patients, we are talking about patients where now there's a disease process that's localized to the soft tissue and the underlying lamina propria or connective tissue. So we have to make sure that we're being prudent about this. I do want to share, this is my gingivitis or gingival scaling kit rather. I've got the QR code in the corner for where to access this. This is this has been this is a kit that was hand selected by hygienists specifically for patients that have gingivitis and need that gingival debridement. The reason why these instruments were hand selected is because of the combination of instrument design and the fact that the way that these instruments were designed, when you combine them together, you're able to get really effective about debridement in unique anatomy, narrow areas. Think about your typical gingivitis case, crowded lower anteriors and things like that. But also instruments that are specifically designed to not create tissue distension or complications where perhaps we're debriding the patient and we're actually creating more in the way of tissue tags or some kind of tissue interruption. So preserving the integrity of that soft tissue becomes really important when it comes to gingival scaling. SRPs, we can get a little bit more aggressive because we've got to be able to get down to the base of all of that funky, unique anatomy. But in this particular case, what we're really focused on is doing swift debridement that doesn't create tissue damage. So I'm a huge fan, particularly this N1 scaler. Take a look. This is an elongated spoon that has a little cutting edge on it that allows us to be able to get straight onto those direct lower anterior linguals and be able to debride, which is really amazing because this offers an opportunity for us to be able to kind of pull that tissue back, get in underneath it, and remove without creating challenges. You got your N2, your Montana Jackson, your Jack B Nimbles. Again, really great for articulating into difficult to reach areas, etc. And here's your Columbia 1314, one of the key universals that does a beautiful job with those two cutting edges to be versatile without creating tissue damage. Okay, so we've done the mechanical debridement, or rather, we know what mechanical debridement is. This is where we start to differentiate from a prophy into looking at how do we treat a gingivitis patient differently from, for example, a healthy prophylactic case. And this is where the journey begins. First, I do believe that when a patient has gingivitis and we're doing this active therapy, that we should be considering topical or some kind of an injectable anesthesia. I personally am a huge fan of Cetacane. I don't know if any of you have utilized this product. I know it's a hygienist favorite. Why? Because you use this gorgeous little plastic cannula tip. You insert it down into the subgingival space. You deliver just a few little drops of the medicament. The medicament kind of flows into that subgingival space. Onset time is about 30 to 60 seconds. From there, you can go in and you can effectively debride the patient, needleless anesthesia, which patients really like. And the important piece is we're starting to see some programmatic content coming out saying that your scaling is actually more efficient when anesthetic gel is used versus if you didn't use an anesthesia procedure at all. And that becomes really important because when we talk about gingival debridement, it is important to acknowledge that a key aspect of this gingival debridement is making sure that we are effective in the chair. And so making sure that we are getting the patient comfortable and we're comfortable with effectively debriding becomes really important. So that's one aspect. And there are a couple of different options that are on the market. In our practice, we just happen to love Cetacane, and our patients do as well. Depending on what state you're in and if this is permitted for hygienists, you could integrate the use of laser bacterial reduction or LAPT. Again, this may be a state by state opportunity for hygiene clinicians. And the data is still a bit out there about if this is effective. There are some really compelling studies that say it is effective. There are other compelling studies that compare laser patients to non-laser patients and don't see an appropriate p-value or a statistically significant improvement, which is why every year we ask for an LBR or an LAPT code from the ADA, and the ADA reviews the data and says, we really don't see any compelling data there. We're starting to see the movement of desiccation shock technology or therapy. This is the use of a desiccant. So sorry, my dog is very passionate about desiccants, as you can tell. This is the use of a desiccant. They go by the brand name Perio DT or Hybenex. And this desiccant really is designed to dehydrate the bacteria, removing water from the cell of the bacteria itself, as well as doing some dehydration, we believe, of the soft tissue. Data's still out on the subsequent results of this. I've spoken to hygienists who utilize this technology or this therapy and say, this is a game changer in my office. I love it. It softens calculus. It's really great. I've had other clinicians say, I don't really see a dynamic difference between. And so again, we go back to the evidence, and I do promise that once I've got some really great data on this, come back and join us, and I'll make sure to share that once it comes out. This is where I want to kind of focus some of my time and attention. That is around a subgingival irrigant. If you went to hygiene school or dental school at the time that I did, you were taught the best subgingival irrigant to use is to load a subgingival irrigating syringe with chlorhexidine. Yep. And we would go ahead and we would place that down into the subgingival space. We would express that chlorhexidine, and in our mind's eye, that chlorhexidine was killing anything down there subgingivally. And we were right. It was killing things like fibroblasts and osteoblasts, which, by the way, we don't want to kill because the concern there is, oh my goodness, now we're killing cells that are helping with attachment. In addition, we learned that Paradex, that mouth rinse that we irrigated our patients with, is actually inactivated in the presence of blood pigmentation. So if there was a bloody pocket and you were irrigating the patient with your typical Paradex solution, it was inactivated. And so that kind of created a little bit of a bummer. This is where we really wanted to start seeing a movement in medicaments that have a good substantivity, meaning they stay down there and they continue to work. And so this is not new on the market, but it's one that we've started to see really kind of pick back up simply because we're starting to see it become an amazing wound healer. So this is a system called the socket gel. It's a little syringe that's loaded with gel inside a plastic cannula tip that gets placed down into the subgingival space. And you're going to see that it is terrific for healing in all different kinds of oral wound procedures. So yes, extraction sites, grafting, implants, laser procedures, but also really great for when we are doing debridement procedures and we need an oral wound cleanser. Now that becomes really important because I want you to think about what's happening down in that subgingival space. Okay. I want you to think about that broken sulcular epithelium. Okay. We've just gone down there with our mechanized instruments, our ultrasonics, our air polishers, our rubber cup polishers, our hand scale, whatever we've done. And now you've got an open wound there. So think about that open wound for a second, right? That open wound, if it continues to remain open, can easily get contaminated. This is the challenge we run into. And I love sharing this during like oral systemic content. I was invited to speak at the Cleveland Clinic a few years back to speak to orthopedic surgeons, to explain to orthopedic surgeons what the pre-med guidelines are for joint replacement. Because let's face it, folks, if you've been practicing as long as I have, it's like every 2 years, we're flip-flopping back and forth in what the heck we do with pre-med guidelines. So at the time, these orthopedic surgeons are like, well, let's invite a dental person out to tell us what our own guidelines are. Because I hope it shouldn't be lost on any of us that what we do in dentistry is just based on the Orthopedic Association and their guidelines. So I was invited out to explain to them their own guidelines. Okay. So I'm there and I'm talking to these orthopedic surgeons and I'm explaining to them that the problem in dentistry is the presence of biofilm, bacteria, right? That we kick up this biofilm, and that biofilm can enter the bloodstream in the subgingival space, and it can begin circulating through the body. And the scary thing is, or the thing that we don't want to have happen, is for that biofilm to stick to that prosthetic joint, right? That's the concern that we have, sticking to that prosthetic joint. And so that's why we talk about these pre-med guidelines, right? Yes, things have changed over the years. Good oral hygiene practices are really important and blah, 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 blah. But the whole point of me sharing this dialogue is I spent all this time explaining to doctors, medical doctors, orthopedic surgeons about biofilm. And I'm spending all this time talking to them about it. And finally, a doctor raises their hand in the back of the room, right? And the doctor goes, I think I've got a solution for you. And I said, oh my gosh, I'd love to hear it. Because this is where true collaboration comes in, right? I'm like, I'd love to hear it. What's your solution? And he said, well, if this is all about biofilm and bacteria, why don't you just put your patients on antibiotics? And I had this moment of like, oh my goodness. Well, first of all, that's nonsense. We will put our patients on antibiotics short term for extreme surgical needs. We'll put our patients on antibiotics as a pre-med when necessary, but we also understand that like antibiotic stewardship is really important because people are, starting to become very resistant, or rather the bacteria are becoming resistant, etc. But I realized something in dentistry, we interact with biofilm in a completely different way than most of our medical colleagues do. They don't spend time interacting with biofilm in the same way that we do. And so I had to explain to this doctor, that's a really terrific question. Here's the challenge. In the mouth, which is warm, moist, the pH is usually well calibrated for the development of biofilm because that's our diet in Western civilization, because of poor oral hygiene habits, etc. Biofilm is inevitable. Within 20 minutes of brushing and flossing, that biofilm is starting to repopulate again. It begins with the acquired pellicle. Once the acquired pellicle starts to form onto the tooth structure, it starts to create an attractant, or we start to get, our free-floating planktonic bacteria adhering to the area. It starts with the early complex bacteria, Strep mitis, Strep aurelis, Strep sanguinis. As that Strep sanguinis, Strep aurelis, and Strep mitis start to repopulate, those are the healthy producing bacteria. But if we don't debride them, we start to see a maturation of that biofilm into Actinomyces series, A. naseolandi, A. israeli. Then we start to see the invitation of Prevotella intermedia, which is your intermediate colonizer. And if P. intermedia shows up to the party, then it's just a matter of time before a red complex bacteria, P. gingivalis, T. denticola, T. forsythia, aggregated bacteria, Actinomycetum comitans, Prevotella intermedia show up to the party. And then we start to see this complexity that starts to form very quickly, right? So I had to do that to help our orthopedic surgeons understand that in dentistry, we actually do know what we're talking about, and we want to have a peer-to-peer conversation about this. But we spend all this time interacting with biofilm. We know that inevitably, after we've scaled and treated that patient, that biofilm is going to reform. And so we want something that is going to close up that wound. We want to put a Band-Aid on that area. We want to put, the neosporin, so to speak, on that area. And that's what this product is. It's not a periodontal bandage, but I want you to think about it like a wound dressing. And so this is really a terrific medicament. This is from our friends at Septidot. And this is a gel that has been designed to be able to be placed into the pockets anytime post-procedure when we're concerned about bacteria re-entering the sulcular epithelium. Great for immunocompromised patients, particularly those that are pre-med, immunosuppressed, where we want to be very careful with that. And then doctors absolutely love it because this is really dry socket prevention, terrific for bone graft healing, implants, etc. Right? Thanks, Heather. I'll be an auctioneer in another lifetime, I'm sure. As far as an optimal medicament to place down in that subgingival space, I'm a huge fan of that OraSoothe. Okay. Then we have adjunctive therapies. These are things that either we can send the patient home with and or additional therapies that we can give the patient. So the first that we'll talk about is probiotics. We'll talk about chlorhexidine. Katrina, didn't you say chlorhexidine was bad? I did. Stay tuned. And then we'll talk about a little bit more in the way of different kinds of options for that oral wound dressing. I'm a huge fan of probiotics. For those of you who have taken my programmatic content, you know how much I value probiotics because the data is compelling. It's there. And it continues to tell us important modalities around what happens when you reintroduce health-producing bacteria back into the oral microbiome. So this is where now we're giving something sustainable to the patient. These are lozenges that the patient takes after their procedure. And this is what allows for, yes, when that biofilm starts to repopulate, when you start to get those layers, right, of, the various types of bacteria that create biofilm, that inside of this, if your patient is taking probiotics, those probiotics should colonize that biofilm. And so what happens instead is if the patient has biofilm, instead of that biofilm being dense with bad players, pathogenic bacteria, instead that biofilm gets colonized with healthy producing bacteria. And the results speak for themselves. These results are stabilization in the gingival index, reduction in bleeding scores, and we actually do see a reduction in plaque index. Why? Because now the plaque cannot severely mature, which becomes really important. I'm a huge fan of the ProDentis line from our friends at BioGaia. There are other probiotics that are on the market. Questions about Stella Life and things like that. There are other probiotics that are on the market. The AAP the American Academy of Periodontology did a meta-analysis looking at various kinds of probiotics. And they said, as a kind of over the balcony view of meta-analyses, that they can't say that all probiotics are effective for patients unless you're talking about a probiotic that contains a very specific bacteria called Limosolactobacillus rhodori, L. rhodori. And so when it comes to probiotics, I'm a huge fan of any probiotic that has L. rhodori because that's where the compelling data is there. Our friends at Stella Life have some amazing rinses that I think are really terrific. And I'm starting to see a lot of surgical cases that have responded favorably. Here's Dr. Spitz. Use them all the time for my surgical patients. So yes, it is a nice medicament that I think does give some really terrific support, particularly when we're talking about, patients that, do have more vulnerable tissue and quick tissue turnover time. Feel free to grab a screenshot of this if you'd like, folks. There are two different ways that you can use this product. One is you can actually deliver it chairside. It comes in a drop form. And that drop form is actually originally was designed for pediatric patients who don't have teeth yet. So yes, this little guy, when he's born, first day of life, we're gonna make sure we get a little dropper of probiotics in there. But those droppers are also really great for delivering those drops subgingivally. And I just recorded some video content on that. So this QR code will take you to a lunch and learn where you can get connected with the BioGaia team. They can talk to you about protocols, and they can show you, some of the resources around how to deliver this chair side. Home care side, we've got those lozenges. Again, 1 tablet or lozenge a day is suitable for your at-risk patients. If they have active disease, we typically will do 2 tablets or lozenges a day. All right. Moving on, we're going to talk about chlorhexidine. And again, I know what you're all saying. Katrina, I thought you said chlorhexidine was bad. I did. Chlorhexidine digluconate. That's your typical mouth rinse, the Paradex mouth rinse, the rinse that we would give post-surgically. Now, again, we're doing things like Stella Life products, right? Post-surgically, really great products for rinsing. And that chlorhexidine digluconate is where the data points to the concerns around poor performance, etc. This is a different form of chlorhexidine. This is a chlorhexidine diacetate, and it also contains an essential oil called thymol. The combination of those 2 products together gives us some really amazing benefits. This is a varnish system from our friends at Ivoclar. That QR code will take you to a Learn and Earn page where you can get connected with the Ivoclar team, request samples, and learn more about the product. But this chlorhexidine-based varnish is exactly what you think it is. It is delivered. Here's a little kind of micro brush. The medicament is in here. You peel this guy open, and then you've got that micro brush that allows you to distribute the product like a varnish. It's a clear varnish. It does not inactivate fibroblasts. It is not inactivated in the presence of blood pigmentation. It does not cause discoloration. It doesn't cause a bad taste in the mouth. You're not going to get staining from it. And it does a beautiful job of not only addressing post-periotherapeutic or gingivitis patients, but you can also put this around dental implants too, and it is quite safe. pH is pretty well neutralized, 6.5 to 7 pH. So pretty well neutralized there. And what's really great is now we're talking about substantivity. We're talking about a time release up to 3 months. So you've got some good substantivity there. You can deliver this and make sure that you're getting some terrific efficacy. There are several different application options for your chlorhexidine-based varnish. Again, gingivitis, a really great product to use right immediately following that gingival scaling. You could also deliver it at a re-evaluation if you still saw some problematic sites in the mouth, right? And then future applications if there's still inflammation. And I know this isn't a course about periodontitis or peri-implant disease, but I do want you to know that we can also use this for perio cases. We can also use this for peri-implant diseased cases. So really terrific there. I've got a question about how are you administering BioGaia in the pocket? There are a few ways that you can do that, Melissa. You can do that through a subgingival irrigating needle. You can also coat a micro brush or a probe and drag either through that pocket space. And again, feel free to get connected with the BioGaia team. I just filmed a 10-minute video that talks very exclusively and specifically about all different kinds of options for how to intrapocketly administer. Is that a word? Intrapocketly? I just made it up if it is. If it isn't, how we would be able to deliver that medicament inside of the pocket. So feel free to check in with those guys. And then again, talking through that hydrogel dressing. So yes, we already talked about that Orasooth socket gel that can be placed subgingivally into the pocket. Please do also know that the active ingredients of socket gel, which by the way are all natural ingredients, so aloe, xylitol, cinnamon clove, wintergreen, thyme, that these medicaments are also enclosed inside of oral coating rinses. So they've got these mouth rinses here, which are really great because they provide that kind of protective film, almost like an oral hydrogel wound bandage, to protect against contamination. The other thing that this particular rinse does, and this is why it's a friendly to our friends at Septodont, they're the makers of Septicane. They're typically in the pain management space, but this is why they work with this product. This product is a negative charged product. And I won't take you on the 50 Shades of Crazy. Do you all remember nerve depolarization and the sodium and potassium channels? Do y'all remember that from local anesthesia class in dental and dental hygiene school? I won't take you there, but it is important for you to know that when a negatively charged gel or product binds to a positively charged sodium, what it does in the pain receptor process is it prevents the acceleration of the pain signal to the brain. And so this, although it will not anesthetize the patient's mouth, it does provide an opportunity. And a lot of us are using this pre-procedurally as a mouth rinse before we probe our patients to kind of block the pain perception when we're probing our patients. So a really great pre-procedural rinse. It's also great pre-procedurally to use before your gingivitis procedure to kind of, anticipate that there may be some discomfort. Um, it's great pre-procedurally anytime that we anticipate that there's going to be bleeding and possible pain. And then great for doctors' patients as well. If we are concerned about, maybe bleeding, if we're going to be packing cord, or doctor's going to be, for example, taking off the temporaries and loading those gorgeous permanent restorations in there, where we want to be, cognizant of reducing that bleeding tendency pre-procedurally. So this is also a really great oral coating hydrogel wound dressing available there. Okay. The final step in the process before we send our patients out is to consider what kinds of at-home care modalities do we want to employ with our patients. And I will tell you, this is what's really, I think, important is having that conversation with the patient to let them know this is a combination of you and I working together, because we've just done the debridement. We've just talked through, a smattering of different kinds of medicaments that are out there. And I do encourage you to explore them. You can take my word all day long, but you've got to use those products, connect with some of these organizations, learn, ask questions about the product. How do you bill it out? How do we use it? Can I get some samples? Can I try them on myself? Try these products out and really find that combination that works really well for you. And subsequently, the patient needs to know it doesn't just end the moment you take your bib off, walk up to the front desk and argue with the front desk about having to pay your deductible. That this continues with the work that you're doing at home. And this is where, again, I cannot stress enough the importance of things like an electronic toothbrush, water flossers, interdental aids for that debridement, but also remembering when we're talking about gingivitis patients that we need to look at targeted things like maybe nutritional counseling, tobacco cessation, or even doing vitamin or supplementation if we know the patient might have a nutritional deficiency. So looking at those bookends, what are we doing nutritional wise, lifestyle wise to counsel the patient? What debridement products are we using? And then remembering that the tissue is the issue. So we might need to do something more for these patients to really address their tissue complications. We've already talked about oral probiotics, but I want to share about where we're starting to see benefits when it comes to periodontal tray therapy. And I got a question here from Linda, mineral supplements as well. Absolutely. If the patient is nutritionally deficient, vitamin C deficiency is one of the more common, vitamin D deficiency we're starting to see. If the patient is nutritionally deficient, then And yes, getting that patient to identify what those nutritional deficiencies are and encouraging the patient to supplement, whether that be through diet or whether that be through taking vitamins and mineral supplementation, is a critical aspect of our care as well. So, kind of rounding out the conversation, when we talk about wound healing. I always think back to growing up. Our friends at Act Dental, their headquarters is in downtown Milwaukee, which is actually home for me. I'm from a small little suburb of Milwaukee, southeastern Milwaukee. And I remember like being a tomboy growing up. I'm the oldest of four in the family. So after having four kids, my my mom was kind of one of those like tough love moms. Um, if I fell on the sidewalk, walked in through the front door crying, pointing to my knee and saying to my mom, oh, it's bleeding. One of the first things my mom would do is take the, brown bottle of hydrogen peroxide and dump it on that wound. Hydrogen peroxide, we know, is a really terrific wound healer. Hydrogen peroxide really starts to kill the disease producing bacteria. And if your parents or your mom was anything like mine and you saw that giant bottle show up, you knew that once the peroxide got in contact with that wound, that you would start to see the bubbling, right? That bubble release of that hydrogen peroxide is what allows for the killing of anaerobic bacteria in the oral cavity. It's what forces oxygen down into that subgingival space. It's important to know that peroxide, by the way, is a natural component of our own immune system. It's made in the liver. It's a component of our white blood cells. So peroxide is actually a natural component of our own healing modalities. So we've started to see the use of hydrogen peroxide in oral wound healing, but I want to be very careful about how I say this. The brown bottle mouth rinse, or I'm sorry, the brown bottle is not designed as a mouth rinse. The brown bottle that mom would pour on my wound was good from a time to time perspective. She'd dump it on the wound. Maybe she would dump it 1 or 2 times on that wound to make sure that it was clean. But she was not chronically using that hydrogen peroxide rinse on my skin. The same is true in the oral cavity. That brown bottle is not designed to be a daily mouth rinse. In fact, that brown bottle could be used in short doses, 5 days or less. But more than that, the challenge that we see is that it starts to alter the oral microbiome. It allows for reactive oxidative species to populate faster. Those are cancer growing cells. And this can create a major problem. So our friends at Perio Protect were like, okay, we know hydrogen peroxide is a great medicament, but if it's used long term at the dosage that we have it in the brown bottle, it's going to actually create more harm than good. So what they came up with was a concept of Perio trays. These are trays that are custom designed for the patient that seat down and force whatever medicament you're going to load into it into that subgingival space. Now that's different than a bleaching tray, right? Bleaching tray, you don't want the gel anywhere near the soft tissue. This is FDA patent approved, where now the gel actually gets forced under, there's a suction that forces that gel into that subgingival space. And now what they do is they've formulated a 1.7% hydrogen peroxide gel. That's really important because at 1.7%, it is high enough dosage wise to do things like reduce bleeding index scores, improve the bleeding upon probing, and improve probing depth, regardless of if the patient is a tobacco user or not. It also allows for wound healing, so much so that patients have reported that their gum tissues are less tender during procedures. However, the dosage is not so high where it creates a negative influence on the oral microbiome. So patients can routinely daily use this product. It's got about a 10-minute contact kill time. So the patients need to wear these trays for 10 minutes a day. But with that hydrogen peroxide concentration, you guessed it, not only will the patients notice fresher breath, but one of the side effects is whiter teeth. Here's a really terrific case example of that. Patient came in, and one of the concerns that they had, here's your pre-treatment, here's your post-treatment. Take a look at how gorgeous that post-treatment tissue is. I mean, take a look at how beautiful, right? Um, Along the way, the clinician noticed that there was a look at that drop in the bleeding tendency, a stark reduction in probe depth scores above 4 millimeter probe depths. And then when you combine the probe depth as well as the bleeding scores, you can see that dynamic drop there. The condition of that soft tissue dynamically improved. And when they did a bacterial load score, they found that there was a 59% reduction in the bacterial infiltrates, the periopathogenic bacteria. So this is called perioprotect tray therapy. If you scan this QR code, you can get connected with our friends at PerioProtect to learn more about how to integrate this in your practice. It is terrific to use in perio cases. We are actually doing some split mouth case studies right now in our practice on implant. Explant cases and using this to condition the soft tissue before we place a new implant in the area, refractory cases, etc. So yes, it's been designed for perio. However, it is an effective product, an effective medicament for gingivitis cases. And again, what's so neat about this is it allows the opportunity for you to help the patient control this inflammatory condition from home. Forcing that gel into that subgingival space means that we're now giving the patients a system that allows them to actually get that wound healing medicament exactly where it needs to go. I want to conclude with I've tossed throughout today's coursework some communication strategies, some opportunities to help share this messaging with our patients. And I'll tell you, one of the greatest challenges that I think we see from a communication standpoint, from an informed consent standpoint, is the fact that this is a missing opportunity inside of dentistry today. That while a significant portion of us do feel as though we spend the time communicating with our patients about their periodontal condition, and while a significant portion of us can say, we really do believe that we're doing a good job of providing a high standard or high level of care, while we believe that we are capturing a very patient-centric approach to communication strategies, that the truth is our general docs actually find that there are opportunities for development. And I think I speak for a lot of general dentists who I work with that say, you know what, I know that there are things that we can be doing to be more prudent in educating our patients. And clarifying that. And I want to acknowledge all of you who joined us today for your candor in sharing in the chat box things like, I want to find ways to better communicate this because I do acknowledge that there are opportunities to communicate this with our patients. I'll tell you, one of the best opportunities is to utilize the term active infection. Data file modalities time and again have shared that 53% of patients are very likely or somewhat likely, 23% are somewhat likely to go to the dentist immediately if they knew that they had an active infection in their mouth. About 3/4 of our patients, if the terms active infection were applied to their oral condition, would seek the care of a dentist. So, we talked about pearls today. We talked about opportunities to be able to communicate and convey this. But it is important to know that terminology like active infection becomes really important. being able to communicate the severity, the seriousness of the disease process is really important. A lot of times we like to sugarcoat how we can. I'm seeing a little bit of bleeding over here. And the opportunity for us to communicate how severe this disease truly is important. Driving urgency to educate our patients and say, this is an urgent concern. And if we don't treat it now, it's not a matter of if, it's a matter of when this disease process will certainly accelerate. And then susceptibility, letting the patient know, yes, in fact, you are susceptible to experiencing inflammatory conditions becomes really important. I go back to the question that Dr. Spitz asked me 2 hours ago. If you guys can believe we've been doing this for 2 hours, this is crazy. But 2 hours ago, when he said, what's one of the things that you would want to convey to new grads coming out into the space? It would be, don't be afraid of your patients. Tell them about the severity of this disease process. Tell them about why it's urgent, that we don't let them just walk around with periopathogenic bacteria in their mouth, why we don't want them walking around with very treatable and preventable oral inflammatory conditions, and the fact that they are susceptible to this, that we've been actively monitoring this, that we have the opportunity to do something so much more for our patients. And so with that, folks, thank you, Diane, for saying this, because time flies for me too, but I don't know, it's just me talking the whole time. It is important to know that a scaling in the presence of gingival inflammation procedure is different from a prophy, that our opportunity to identify those cases and therapeutically treat those cases becomes really important. And administratively, that there are a whole host of documentation modalities that we have at our fingertips to make sure that we're capturing all of the important pieces that we need for both our patients and our third-party payer partners. With that, I want to thank all of you so very much for your time today. Thank you for the fabulous questions that you asked. Thank you for your participation. Thank you to the wonderful folks of ACT Dental University. Friends, I actually spend a lot of time hanging out with our friends at ACT Dental. They do invite me back home to Milwaukee on occasion, where I get to present shops there. So if you loved what you saw, please keep your eyes on the amazing things that ACT Dental is doing, because there may be opportunities down the road for us to meet in person and for you to take one of those long Katrina Sanders workshops. In the interim, please feel free to connect with me. I'm the Dental Hygienist on Instagram, and I post educational pieces like this all the time. So if you liked what you saw, please feel free to zip into my Instagram or Facebook account, or feel free to join my newsletter where you can learn about all of the fun adventures of where I'm going, what I'm doing. With that, I'm going to turn the microphone back over to my dear friend and colleague, Heather. Thank you so much for inviting me to be here, and thank you all so much for joining me. Heather, back to you,
Trina,
girlfriend.
you were phenomenal. I'm going to let Angela finish this out and do any housekeeping.
Thanks, everybody. Thanks, Katrina. Thanks for that shout out, Carrie McDougall, too. I love that you did a watch party for your team.
So
that's
Seeing
awesome.
that.
Yeah,
That's
this is
so
really
cool.
amazing.
I love
Aw,
that. That's so cool.
that's amazing.
I've posted in the chat a couple of times the link for the CE, and then I've tried to keep up on the QRs to enable just like a link for those of you who are maybe on your phone and weren't able to scan a QR at the same time. I've added those. So head to the chat. I love all the messages that are coming through.
I know, you
Aw,
guys are
good
amazing.
luck with baby Stuart.
Thank you. I love this speedy delivery. Amen, sister. That's the birth plan, is a speedy delivery.
Oh. Katrina,
Oh.
do you have time for just one question?
Yeah, of course.
How would you get started if you're a hygienist here in the room today and you're in an office with, or maybe your doctor hasn't had the education that the hygienists do? What would your first step be to get them on board?
I think this is a really important question. I don't know if Dr. Spitz is still on, but I'm gonna pick on him and ask him. He is, haha. Dr. Spitz, I'm gonna ask you to toss into the chat box what you think, how you would want your hygienist to approach you, just to get his feedback on this, because it's always important to learn from our doctors, right? I will say, timing is everything, and presenting this in a way that makes sense to your doctors is everything. Um, in the morning, when we're about ready to run to the morning huddle, at the end of the day, when doctor's trying to run to their kickboxing class, right after doctor just did a root canal and they're like kind of confused, and you're like, I think we should do this 4346. I took this course with Katrina Sanders over the weekend, and I think it'd be really great. And this is the procedure I want to do. None of those are the optimal times to say, I think there's an opportunity for us to change the protocol of what it is that we're doing, right? Um, I think there's an opportunity for you as a hygienist to approach your doctor and approach your colleagues and say, hey, I've taken some coursework in gingivitis therapy, and I believe that there's an opportunity here for us to do better care for our patients. You may even want to, and I've done this, in an office where I've approached a doctor and said, hey, I want to start this. In this example, I wanted to do laser in the office. I actually collected data for the number of times that I was doing perio maintenances and SRPs. And I said, these are all of the patients that I could have done this procedure on. So, I saw X number of, and you can go through your hygiene column and, maybe for a week, collect the number of patients that you diagnosed with plaque-induced gingivitis and say, over this week, I saw 12 patients that we could have done this treatment on. And I want to talk to you about what it would look like to implement not only this procedural code, but also a protocol that we all feel good with that could address soft tissue issues. So would you be open, doctor, to doing a learn and earn with Ivoclar or Septidon or PerioProtect or BioGaia? Would you be open to sitting down and learning about some of these products? And let's just learn, like, we're not going to commit to anything, right? Especially if your doctor is a male. I've learned this being married now. Like I would take my husband to the car dealership, and I'm like, we're not gonna commit to, we're not gonna buy a car. We're just gonna look, right? Got to start with that. I did end up leaving with a car, by the way, but that's a different story. It's important to say, like, we're not gonna commit to anything, but I think it's really good for us to take the time to learn about what's out there. And then would you be open to sitting down as a clinical team and talking through, okay, what would it look like to implement this code? What adjunctive services do we want to use? How do we want to follow up with a re-eval in this case? What would it take to involve our administrative team in this? What would those patients look like? When do we want to start? Do we want to dip our toes in that water? Do we want to start by in the morning huddle going, you know what? I noticed this patient last time. So maybe this is one of those patients, right? We do that with Invisalign. You go to an Invisalign course and you're like, okay, now I learned that if the patient has abfractions and has lower anterior crowning, well, we should talk to them about it. And then you get to your morning huddle on Monday morning and you're like, hey, remember when we took that Invisalign course over the weekend? Yeah, I think that my patient at 10 a.m. could be a good one. Cool. So let's build a plan team. What are we going to do? 10 a.m. patient comes in. Well, I'm going to scan them. I'm going to do that, right? We do this with other things. Let's think about how we as hygienists can be leaders. Dr. Spitz says, I love direct communication. I love when my hygienist talks to the patient, then fills me in on what the suggestion is. I have the opportunity to agree or not, but it at least opens the dialogue. And that's exactly it. Don't surprise your doctor, but do let your doctor know, I took this coursework and I'm very interested in implementing this in the practice. You do need to get buy-in because in most states across the United States, hygienists, we cannot legally diagnose those patients. Our doctor has to. Subsequently, they have to be able to diagnose what that treatment is. But your reasonable doctor, I use the keyword reasonable, your reasonable doctor who's there delivering care and wants to do right by their patients, which is why I asked Dr. Spitz to weigh in, because I know he is one of those doctors that does care about the success and outcomes of the patient demographic there. That your reasonable doctor is going to be open to having that dialogue. You might need to be a leader hygienist in the practice and take that and not make the doctor do it. You might have to be the one to say, great, I've set up a lunch and learn with this. I've set up this with that. We're going to sit down. Doctor, we're going to go out for happy hour. You're going to buy that. Then we're going to go and do that. You might need to be the one to take the lead on that. So just be prepared for that. But I think that's a really exciting opportunity. That's what we're here to do, hygienists. We're here to advocate. That's why we take these learning opportunities.
Awesome.
Yeah.
Thank you, Katrina, so much. We haven't published it yet, but I know that you're coming back for what we're calling summer school next year. Um,
Awesome.
2 dates in June where you're going to join us virtually. And so, like Katrina already mentions, sign up for the ACT emails and the Katrina emails, and we will tell you guys all about that when it gets closer. So, all right, Katrina, thank you once again. Heather, thank you. Everybody, thank you. Enjoy your Friday, and we'll see you next time.
Thank you,
Bye.
everybody.
Katrina, Ange, bye.
Thank you. Bye-bye.